Good morning or good afternoon, wherever you may be. Bonjour tout le monde. So let me recognize the presence of the WHO Regional Director for Africa, Dr. Matshidiso Moeti, who's going to be our keynote speaker. And I know she is very, very busy. So Dr. Moeti will be able to forgive you any time when you do have to leave. Colleagues, I bring you great greetings from my co-chair, Lord Nigel Crisp, and the board of Nursing Now. We have with us the secretariat right here to support us, so we are very grateful to them. And please note that we have translation in French, so be free to tune on to that one. But therefore, I'll be able to ask, I'm trying to ask the speakers to speak slowly so that they can be, the translators will be able to interpret it very, very well. So I'm also bringing you greetings from the HIV Prevention Coalition because they gave me permission to be with you this morning. As you are aware, tomorrow is World AIDS Day. Let's not forget that we have COVID-19, but we cannot forget that there's another epidemic that has really affected Africa and globally has left more than 39 people dead, 39 million people dead. So it is a major problem for us in Africa. And we are saying, let's not money from one epidemic be used to treat another epidemic, because in the ultimate, both of them are equally important. A warm welcome to you, my fellow health professionals. I say that at no time in the world has the spotlight of health been, the spotlight of the world been shown on us more than it is now. And indeed, I remember a conversation I had with Dr. Moeti a few weeks ago, and I was saying to her, how are you? I was just empathizing, and she says to me, you know, I have never worked so hard in my life, except when I was still at the AIDS STD unit of the Ministry of Health of Botswana. And I remember those days when, you know, we were running around, people were dying, and she was heading the AIDS STD unit. And I know she was really running around that time. So I do empathize with you, my sister. We pay tribute to our colleagues who have lost their lives trying to save the lives, you know, of the people during this pandemic. And we pay tribute to our colleagues who put in long hours of care and support, despite the fact that the lack of PPEs, and it is getting worse. And so you have that fear among them, that psychological trauma of possibly becoming infected or infecting their own family members. So for us, the reality tester today is that in the next decade, shortage of nurses will remain one of the biggest problems that national health systems will globally face. It is estimated that by 2030, the world will be short of 6 million nurses if we do not do anything about it. And unless this shortage is addressed, the World Health Assembly goal of 1 billion more people benefiting from universal health coverage in 5 years' time cannot be achieved, especially for us in Africa. So this webinar is very important. For us, nurses are the frontline health workers in all our countries, and they make up 50% of the global health force, providing 90% of patient contact with healthcare workers. They are often placed to lead in health promotion and disease prevention so that populations can better understand and care for themselves. Indeed, for this COVID-19 pandemic, in some of our countries, we finding that the nurse is the first person you see, and sometimes the last, especially when you get discharged, and even more so when you pass on. You know, that Virginia Henderson theory of leading the, you know, supporting the patient to a peaceful death has never been so real, especially like right now, because with families not being allowed to visit, sometimes the nurse is that only source of comfort for the patient until they pass on. So as co-chair of Nursing Now, we have worked with the International Council of Nurses and WHO to urge all governments to invest in education, training, recruitment, and retention of nurses with decent pay and working conditions. And that's what a lot of our panelists will be talking about as to what we can do. But let me end by saying that we have actually a tool. You know, I always say, if you are doing advocacy, evidence hits any one policymaker straight in the face and they cannot ignore it. So the tool for us is the State of the World Nursing report that was published in April 2020. The first time a report about nursing has been written, has been produced on such a global scale. And therefore it is vital that we provide insight into the challenges faced by nurses around the world, but also it helps to hold governments accountable and demand that positive work, work should be done for the health of our people. So that's what we'll be talking about in this session, whose objectives are to promote dialogue between nurses in the Africa region and policymakers at national and regional level, to highlight areas for investment in nursing development needed in the region to support sustainable development goals and universal health coverage, to support development of global and regional strategies for nursing by WHO, the ones that will support the regional and country nursing and health workforce development needs. Now, to go deep into this and to share best practices, I have the keynote speaker, and also a great selection of panelists comprising of nurse leaders from all over the Africa region. So I will start with Dr. Moeti, who needs no introduction, but for me, she has been a sister, she's been in the AIDS response, and actually is the best person now to be heading that COVID response in Africa. She has worked in Botswana in all the countries representing UNICEF, WHO, and now she is, of course, representing Africa at the WHO regional office in Brazzaville. We miss her at home. I've worked with, she's been a sister for me. We've been together forever since our high school days. We used to even study together because she was clever, and I knew if she gets a first class pass, I'm gonna get it. So it was really great. And we've been together, and I think we'll always be together, even as old women, now reminiscing and maybe writing memoirs, because she and I were the first to document the experience of women and AIDS in Botswana and indeed in Africa. So with that, Dr. Moeti, we acknowledge you, we pay tribute to you, and please let's hear you inspire us. Over to you.
Thank you so much, Sheila, my dear sister and friend and companion in mischief at some points in both of our lives. Thank you for having invited me. So I'd like to say good morning, bonjour à tout le monde. My sincere thanks to Nursing Now and the organizers, the leadership, for having invited me to be part of this very important discussion about investing in nurses and nursing, in their recruitment, in retaining them, educating them, and most importantly, in promoting, developing, and in fact, benefiting from their leadership. So I'd like to greet nurses all across the region, all across the continent and the world, as I've seen, who are joining this event, and greetings to all the participants. It's a huge pleasure for me to be with you this morning and to hear from you, although I have to apologize in advance for the fact that I will need to leave before the discussion is finished, about your ideas, your experiences that will help all of us, particularly national governments, development partners who are working in health, ourselves in WHO, the nurses themselves, help the world to benefit and to leverage to the maximum the leadership capacity and the talents of the women and men who work today as nurses. I start by truly appreciating the tireless work of nurses and indeed of all healthcare workers, but particularly nurses, during this very challenging year and in the context of the COVID-19 pandemic. In the WHO African region, which is mainly sub-Saharan Africa and Algeria, COVID-19 has infected about 55,000 healthcare workers, and many of the people affected who got ill and who have lost their lives are indeed nurses. So we'd like to pay tribute, I'll join you, Sheila, in doing that, to nurses and other health workers who have sacrificed so much in the course of providing care for everyone, and whose families have also sacrificed a lot. We won't go into detail about that, but I've been involved in discussions where people share what it means to be going into these risky contexts and then going back to your family, how your family might get stigmatized because of the work that you are doing, and how you have worried about your family as well. I'd like to say every life lost is a tragedy. And as nurses, you know this better than most of us, because it's often you who support and comfort families of patients in their times of grief when they've lost a family member. At WHO, we've dedicated 2020 as the year of the nurse and midwife, in recognition of the incredible work that you do, and recognizing that more awareness and definitely more investment is needed in nursing and midwifery as a backbone of health systems globally. Nurses are on the front lines every day, and I see this myself as I visit different African countries, promoting health, saving lives, and serving the vulnerable, and making sure that essential health services continue to be provided even in times of crisis, and particularly at the primary care level. From a global perspective, nurses and midwives are critical to ensuring that no one is left behind in the worldwide effort to achieve universal health coverage and the Sustainable Development Goals. As nurses, you are making the difference in advancing psychosocial support and mental health care, in prevention and control of non-communicable diseases, in infection prevention and control, and there's never been a moment where the importance of that has been greater, in patient safety, and in the overall delivery of integrated, people-centered care. At WHO, we are determined to maximize the contribution of nurses and to strengthen their roles within interprofessional health teams. In the past 15 years, the number of nurses and midwives in the WHO African region has nearly doubled, from 762,000 in 2005 to 1.38 million today. However, relative to the population growth rate, only 27 of the 47 countries in the WHO African region recorded real improvements in the density of nurses and midwives per inhabitant. More than half the health workers in the African region, that is 53%, are nurses, and long-standing critical shortages of nurses and other health workers mean that many nurses are overworked and taking on additional tasks without the requisite time or training. We can all attest to this. And the more one visits, particularly rural areas where the life is harder, the work is harder, we see that quite often nurses who are in charge of health facilities literally never knock off, literally never feel freed of their work, and are so essential in places where no other health workers are present. In the African region, there are fewer than 9 nurses per 10,000 people. This is 10 times less than in the WHO region of the Americas, for example, where there are 83 nurses per 10,000 population. It's estimated that the African region will face a shortage of 2.8 million nurses and midwives by 2030. And this shortage jeopardizes the attainment of the Sustainable Development Goals. Realizing the need for urgent action to address this shortage, 7 African countries have conducted comprehensive health labor market analyses to make the case for more investment in the health workforce, particularly nurses and midwives. They provided evidence that investing in the health workforce contributes to national development. This is very obvious. As a result, in some of these countries, the Ministry of Finance has committed to increasing the budget for the Ministry of Health in order to recruit more healthcare workers, particularly nurses. Investment in the health workforce starts with education. And in support of nursing education, WHO is working with countries to strengthen regulatory frameworks and competency-based training. For example, colleges of nursing in Lesotho and South Africa have developed competency-based nursing curricula using WHO's regional prototype curriculum. Eswatini developed a competency framework using WHO's regulatory guidance. And as examples, Malawi, Namibia, and Sierra Leone have also used these tools. 10 African governments are already investing in specialist nursing education or advanced practice in child health, oncology, emergency care, and women's health. These are registered nurses who have undertaken post-basic training leading to qualification as specialist nurses. However, there are ongoing challenges that countries face in producing sufficient numbers of nurses and midwives. These challenges include inadequate infrastructure, limited nurse educators, and the need to update teaching and learning materials such as skills labs for practical training. In addition, due to dwindling financial space for health workforce recruitments, some graduate nurses are forced to wait for up to 4 years before landing a role in their chosen profession. This has in turn encouraged high rates of out-migration of nurses and midwives in some African countries. And we know so well and so painfully that we cannot afford that. The WHO Global Code of Practice on the International Recruitment of Health Personnel sets out principles and practices for ethical international recruitments and health system strengthening, but more needs to be done to ensure that it is implemented and enforced and to make sure it contributes to protecting health workers and building resilient systems. Health workers, particularly nurses, are a precious resource in our health systems and societies, and more needs to be done around retention and the development of career pathways. In 2010, WHO produced a comprehensive evidence-based set of interventions that are known to promote the retention of health workers in rural and underserved areas, particularly nurses, including rural clinical placements, continuing medical education, bonding schemes, compulsory service, financial incentives, and other incentives which I have learned are very important as well to encourage colleagues and nursing colleagues who are often at the front line, as I said, in the most remote places, sacrificing hugely so that they stay in their jobs and contribute to health. Professional support is also extremely important. The retention of nurses and midwives in these areas remains an absolute priority, and policy actions are needed to expand these interventions and monitor their effectiveness. And here, hearing from nurses themselves is hugely important. We also know that nurses make great leaders and managers. I've been lucky enough in the context of Botswana to work as an officer under the management and leaders of nurses, and Sheila is a product of that system. And I have proof myself that you can have nurses as leaders of district health teams, of units and departments in the Ministry of Health, and they function extremely well. This has been proven. It just needs to be known better and to be carried out. Investing in nurses' capacities in these areas will enormously improve outcomes for patients, as well as the efficient use of resources and job satisfaction and career opportunities among the nursing cadre. Many countries in the region already have chief nursing and midwifery officers or similar senior leadership roles. This is important for ensuring that the nursing perspective is taken into account in health policies and strategies at the highest level, as well as being brought into service delivery right down to the most peripheral level in health services in countries. However, in some countries, these roles do not yet exist, and advocacy is needed to create these roles and amplify the voice of nurses and midwives at the policy level. At WHO, we're also working with partners to train more nursing and midwifery managers at the policy and operational or frontline levels in the African region. Looking ahead, in 10 years' time, by 2030, a global shortage of 5.9 million nurses is anticipated. So now is the time to be bold and confront these challenges. Government should embark on comprehensive health labor market analysis to generate evidence for policy dialogue towards needs-based planning for the health workforce, especially for the nursing and midwifery cadres. Training of nurses and midwives, both general and specialized, needs to be scaled up to overcome these shortages. Countries are already training 2 nurses for every retiring nurse. But to curb the projected shortage, this would need to increase by at least 10% each year until 2030. Competency-based training should be adopted with harmonized curricula to produce fit-for-purpose nurses and midwives. Investment is also needed in the recruitment and retention of all trained and qualified nurses and midwives, as well equitable deployment to ensure that every person in our communities is able to access healthcare. Sheila has spoken about the work that I've done in HIV, both in my country and at the global level in UNAIDS and in WHO in the regional office. I have to say, when we rolled out an access to antiretroviral therapy program called the 3x5, it was very clear to us that nurses would be at the forefront of seeing patients, prescribing care, and following up. And it is the contribution of nurses that made access to treatment at one of the most difficult moments of the HIV pandemic for Africa a reality for many people and saved millions of lives. Finally, but certainly not least, governments, partners, and communities need to invest in nurse leadership to maximize the efficiency and effectiveness of health and social care systems. As I've said, some of us have worked in countries where we've had the privilege to observe the leadership role of nurses at the very top level in ministries and see how it can contribute to health outcomes. In closing, I therefore call on governments, on the private sector, on academic institutions, and civil society groups to expand investments in accelerating nursing education, job creation, career pathways, and leadership. This will have benefits for generations to come through better outcomes for patients, their families, and national development and prosperity. Again, I'd like to thank you so much for having invited me to join you in this very important meeting. And Sheila, I hand back to you. Thank you.
Thank you very much. Thank you very much, Dr. Moeti. And those are really very inspiring words. I know definitely that you and I are great examples of interprofessional collaboration and really, as you say in Botswana, having nurses at higher positions of decision making. What we are taking from you is really to also include, to ensure that we look a lot into the WHO website, because you mentioned 3 documents that are very useful as we work. The competency-based framework, as well as the WHO regulation guidelines, so that those should actually enable countries to be able to say, how do we plan? But the one important one is really the WHO code of practice as a tool to use in the retention, in the education, and everything about nursing and healthcare workers. I know in there's also actually a call for collaboration for countries to say, look, you call that again, civil society, not just government, civil society, the private practice, get together and collaborate and educate those nurse leaders, those very lecturers and the faculty that will be able to educate future nurses and invest in that leadership of nursing. So with those ways, we really admire you, and we think that we can be able to work with you as you are strengthening the role of nurses and midwives in Africa, among African countries, and urging them to really increase that 9 nurses and midwives per 10,000 population to make it better, even better than 83. Because if you, as you say, some of these people, the 83 per 10,000 are actually nurses who have come from Africa. So in our countries, we need to do a lot more to make sure that as we educate, we also make sure that we employ with great working conditions, and we're able to retain people. But that's also, of course, a political thing. So with that, we thank you very much. And let me now move to the panel discussion, to the panelists, because those are the ones that will really give us a way of, in real practice terms, what is it that can be done. I have a group of 8 panelists. Yeah, I think there are 8. So I'm going to mention who they are, because then when I ask questions, they'll be able to answer, as one panel. But what I want to point out is that when you have questions, do make sure that you put them in the chat box. That way, after the panelists have spoken, I'll be able to go into the chat box and try to get some of the questions. So far, I'm seeing none in the chat box, except greetings, and we appreciate all the greetings from Mexico, from the world. It's really great. So the panelists that I have is Faith Nawagi, GEMX Global Partnership Development Representative in Africa. I have Judy Khanyola, Chair, the Center of Nursing and Midwifery, University of Global Health Equity in Rwanda. I have Simon Hungwani, Sanam Treasurer, and DINOSA President. DINOSA is Democratic Nursing Association of Society of South Africa. I have my own president, Kiwagetse Khwabi, president of Hexacon and principal nursing officer 1 at Gweta Primary Hospital in Botswana. We have Sello Ramokanate, a young nurse in Lesotho, Dr. Mary Nandili, chief nursing officer, Kenya, Francisca Okafor, Deputy Director, Nursing Division, Federal Ministry of Health of Nigeria, and Beatrice Lukeni, Resident Responsive Health System Project Director at DRC ICAP, Columbia University. I think I may have missed somebody. How come I don't see a Ugandan here? But I'll see. So anyway, let me go to the panelists. The first question to panelist 1, that's Faith, Judy, Simon, and Kuwagetse. What investment do you urgently need for nursing in your country? It's really saying, if you had the opportunity to ask your Ministry of Health for an investment in nursing, what would it be for? So you each have like 5 minutes to answer that. So over to you, Faith.
All right. Thank you so much, Professor Sheila. So if I had the opportunity to ask my Ministry of Health, what is it that they would invest in nurses? I think I would tackle 4 key main areas. First is the well-being of the nurses. We are training, we are putting out a health workforce, but we hardly have efficient psychosocial support systems for the nurses at the workplace. So it's one thing to train and make sure people are there doing the work, but it's important that the people doing the work have a proper psychological, emotional well-being as they serve at the front line, especially in COVID and all that. So it's important that there is a psychosocial support center for the nurses and even other health workers that are serving at the front line. I would ask my Ministry of Health to invest in the strategic plan for the nursing profession to enable guided interventions and progressions of growth of our profession in the country. I would also encourage our Ministry of Health to invest in our operationalizing the schemes of service for the nursing profession. It's there, it's drawn, but it's important that it's effected up to the grassroots to ensure that the proper cadres are the ones serving the populations of Uganda at large. I'd also encourage them to invest in the leadership training, research, and innovation centers for the nurses so that they are able to be contributors to knowledge of care in the country as well as globally and regionally in Africa. Thank you.
Now, thank you very much. And now over to you, Judy. She talked about strategic plans and operationalizing the schemes of our service. So, Judy,
so thank
over
you
to you.
Sheila, thank you very much. Lovely to be here this morning. And if I was to answer that question, what investment do you urgently need for nursing in my country or in Africa? And if I had the opportunity to ask my Ministry of Health or my Minister of Health for an investment in nursing, what would it be? I think for me, I would answer just two things, really. A dedicated Department of Nursing and Midwifery budget. Every nursing and midwifery budget in the Ministry of Health in all the countries of Africa requires a dedicated budget. That is number one. The second thing is this budget, once it's there, should be managed by the chief nursing officer, chief midwifery officer of that country. She should be the ultimate and final accounting officer. She should be held accountable for that budget. If you can trust nurses and midwives with your lives, I think you can trust us annually with a few millions of shillings or rands or cedis or nairas or francs, as the case may be. The next thing is that every country in Africa, the 54 countries that we have, should have an office of the chief nurse or the chief midwife without fail. We need these people at the Ministry of Health. Some countries in Africa have them, some don't. I think this is just a bare minimum. Every country in Africa should have a director of nursing services, a director of midwifery, or a chief government nursing and midwifery authority. This person should have a dedicated staff, a budget, and resources to do her work. In addition, no window dressings, please. This chief nursing officer at the highest level should have full authority. I'm tired of nurses being given titles without the relevant authority. I'm tired of nurses being given responsibilities without then the necessary authority. Change the policies and legal framework to allow this. Then lastly, Sheila and everybody here listening, I would ask for a small investment in each country in Africa, just a small budget that will allow for a coordinating, overarching framework of the Quad in each country. The Quad in Africa is made up of the Ministry of Health, which works at policy, the key education and training, the people who produce the nurses, the associations who look after, the national nurse associations who look after the welfare of nurses, and last but not least, the regulation of the profession. These four arms should sit at the apex of nursing in every country. There should be a budget for them to then be able to coordinate nursing within each country. Thank you, Sheila.
That's a great one. Thank you so much, Judy. Yes, as you say, a dedicated budget for nursing and midwifery run and managed by the nurses themselves. And indeed, well, as you say, if somebody can trust us with their lives, they can trust us with money, a lot more than men. The world has shown that when she leads, there is less corruption. So maybe it is high time that we did that and we actually shown what we are made of. So, and indeed, the chief nursing officer, complete with staff as well as resources, and no, no just titles, the real gist of it. So let me hear now from Simon. Simon, Lungwan.
Good morning. Good morning, Siapila Ninjani, and thank you for having me and inviting me. Well, in my mother tongue, there is a saying that says, a dead hero will save no one. So I think if I were to have an opportunity, would be to request or plead with the ministry to say, invest in the well-being of nurses, in that wherever the nurses will be, they should be protected from any injuries, any disease, any harm when they are on duty. As a result, I would take it as a major priority, because we need these nurses to be heroes that will be alive and saving many other lives. If they were to die, as you can see now, even including the death rate of health professionals with COVID-19, it means we are less the number that we used to have before COVID-19. Therefore, it is of utmost importance to make sure that at least there's protection with the provision of the necessary apparatus that includes the PPEs to make sure that nurses are protected from any diseases and any other injury would plead for would be a in order for us, and I would even of World Nursing Report, which recommends the percentage at which each country should be increasing the training on annual basis. That would be around 8 to 10%. For us as African countries, it's even worse. So we do need to find a huge investment in that space, but also an investment in the training of advanced practice nurses, because what we have also seen is that we find ourselves without advanced nurse practitioners, particularly for critical care areas, for trauma units, and so on. So the investment, if it is to be increased in that space, then we'll be able to have enough of what we could be needing as a country. But in order to prevent and make sure that there's good health promotion, the prevention of diseases, a huge investment would be needed to ensure that we have adequate nurses within the communities, rural areas, deep rural areas. In other words, we make sure that we are not hospital-centric, or we're not hospital-centered in terms of our care. Nurses must go to the rural areas, to the communities at large, and take good care of the community in society in general. We don't wait for people to get sick, but we go and teach them how to prevent injuries, how to prevent diseases, but also to assist them in terms of health promotion. In that way, we avoid people from getting sick and going to the hospital, because we know that we're going to be flooded and changing the focus from looking into strengthening the hospitals, but strengthen community-based nursing itself, and then working together with what we could call community health workers within the communities. Also to invest in the research and invest heavily in the collaboration where we can learn best practice from us, be able to, as a country, learn that research so that we can collaborate. And I've noticed in our countries that whatever happens in each country, it spills off to the another country, including ourselves. So we stand to gain. And if we can be collaborated, we can stand to be more stronger and work together within these countries. That will be my focus, Chair, for the request of the funding that would need as an huge investment that will change it, because we must prepare our countries to be ready for the next health disaster in any form or any pandemic that may occur. So we need to ensure that we can strengthen the health system to be more resilient. That is my input. Thank you very much, Chair.
Thank you very much, Simon. Indeed, a dead hero saves no one. In Setswana, we say, so we are calling for the protection of nurses, especially around this time. So you've talked about the investment, especially and in training of advanced practice nursing. In fact, with our statistics, we are actually seeing that 74% of the countries in Africa have APN roles compared to only 53% globally. So maybe we, as we talk, we can be able to then say, how do we improve on that? Because you mentioned a very important aspect of the role of nurses in prevention and disease prevention and health promotion at community level, working with communities so that they can empower themselves. So thank you so much. And the last one, of course, is Meg Kwabi, who is the president of Hexacon. So you are speaking for a lot of people. I'll give you a few more minutes. So Kwahesi, there we are.
Okay, thank you. Good morning, everyone. Good evening, good day, wherever you are. Am I clear?
Yes, Kwabi.
Can we hear me?
Yes, Kwabi, we can hear you.
Yes, we can hear you. Yes.
Thank you so much. So for me, what investment do I urgently need for nursing in my country? I will just start with a very disturbing situation right now, which we are having of nurses' safety. Nurses in our country are not safe, be it at home or even at work. We have recently seen situations where nurses are attacked at work, be it verbally or they are beaten, and even sadly, they are raped while giving their duty. So I would really like the ministry to look into the issue of nurses' safety by providing proper security for nurses while they are on duty. Secondly, I will request that nurses have homes nearer their workplaces. We see nurses when they knock off from work, they are attacked also because of the distances that they have to travel in order to go to their homes. So by so saying, this makes nurses to be always in fear, especially when they are working at night and there is no proper security. People come claiming to be patients and then attacking them. We also have cases where in rural areas, the nurses who do not work 24 hours on service, but there is what we call back to duty. Some people will go to their homes claiming that they are sick. It is very dangerous for people to go to their nurses' homes to collect or to care, to inform them that they have sick relatives. And we have seen nurses being beaten by people who claimed that they came to collect them to go and help their sick relatives. So this really has put nurses in a very dangerous and unsafe situation where they are always complaining and very insecure. I would also like my government to look at training nurses at higher levels. As we all know that in Africa as a whole, we have nurses working in remote areas alone, while others may be working in hospitals where they have doctors as their colleagues and partners. Nurses are working alone, and we need nurses to be prepared at a level where they can make decisions on the patients that they are caring for. So in Botswana and in some other African countries, more nurses are trained at diploma level. I strongly feel that diploma level nowadays is so low, and we need nurses training at degrees and masters and even above, where they can decide alone and make better decisions and better care for their patients, where they can do their duties properly for attainment of the Sustainable Development Goals and universal health coverage. As they work alone out there, they are the ones who have to take care of all situations like immunizations, situations like caring for pregnant women. So we need an all-rounder nurse who has knowledge in all areas. So I would like my ministry to look into that. Of course, yes, we might say we have some higher level training institutions, but very few nurses, especially those in clinical area, have master's training. We see most of the master's trainees and PhDs in training institutions, but at clinical area, we have very few. So this is one of the things that I would really like my government to consider. I would also like the ministry to consider the regulatory body to be independent. We have so far had situations where we feel that if the regulatory body is independent, it will deliver its mandate freely and autonomously. If the regulatory body is under the Ministry of Health as it is right now, they have limitations to do without being sometimes influenced by the employer, because obviously they are employees of the Ministry of Health. So if they are employees of the Ministry of Health, then it means they have to do most of the time what the employer wants. But if they are independent, they will regulate the schools to see if the schools have been accredited. They will regulate if those who go into nursing are fit to go into nursing. Then also I would like to talk on something that one of my colleagues has already mentioned, capacitating the office of the chief nursing office. In Botswana, the chief nursing officer at her level, she doesn't sit at the decision-making table. Decisions are made from director level above, and the chief nursing officer is below that level. So in a way, she is not able to sit at that decision-making. And things which have been discussed for nurses, they just come to her as a second information. I would really want my ministry to consider having an office which will allow the chief nursing officer or even the director of nursing. Let me be specific to say we need the position of the director of nursing, because we have realized that decision making is done from director level. So we want the director of nursing with equipped and enough staff. So these are the things that I would really like my government to consider, and I will end so far. Thank you so much.
All right, thank you very much. I think you've spoken for all when you're talking about the security for nurses at work and in their homes. Indeed, in a lot of our countries, we have not kept up with both societal changes. The fact that now, violence seems to be almost like a daily affair in a lot of countries. I know Botswana used to be a very peaceful country. It still is relatively more peaceful than others, but indeed, the art aspects and nurses are no longer as respected as they used to be. Before, I know at night you could, if you are a nurse, you could even be escorted to your home, but that has changed. And indeed, the independent regulatory body that can follow WHO guidelines properly without any undue influence is most important. Yeah, thank you very much. So let's give those panelists a hand, a virtual hand, because now I'm going to panel discussion to the panelists, the second group, which is really looking at what we can learn from the State of the World Nursing Report and how can we improve the situation in Africa. So really it's looking like at, in your opinion, this is the question, has nursing education in your country kept pace with population needs? So where do you see the gaps in nursing education? And of course, not just gaps, what can be done about them? So I'll give it over to you, Sello. Actually, I haven't even seen your face. Sello, are you around? Oh, you are, okay. Okay, Tata Sello, Ribuje. So we'll start with you, yes.
Thank you very much for having me, and a warm hello to everyone. In my opinion, honestly, nursing education in my country has not kept pace with the population needs. And the gaps that I identified in nursing education are as follows. For one, the curriculum is not responsive to the needs, but merely the programs that we have orient learners to nursing and health in general, without necessarily taking cognizance of the advances that are occurring in reality, socially, politically, economically, and otherwise. Also, I think there's a dire need to integrate primary health care into basic training of nurses, or at least effect a policy that makes it compulsory for our nurses to qualify in primary health care as well, as it was done with midwifery in response to the high maternal mortality rate. Number two, I think the country has not responded in a way that we still don't have the relevant specialties in training. I'm talking about specialties such as intensive care unit nursing, theater techniques, anesthesia, and so on. And this really is evidence that we have not kept pace with the population needs. Number three, I think we have a bit of a challenge with nurses who are now getting qualifications via research or by research. And it is unfortunate because our nurses are now engaging on qualifications by research, and yet they are still hands-on in clinical practice. I will make an example where a nurse will enroll in a master's program in psychiatric mental health nursing by research, and then be expected at the same time to go back to a psychiatric hospital and function as an advanced practice nurse. It really doesn't suffice, and it doesn't respond to the needs of the public. And last but not least, we have a lack of community service or adequate clinical rotations during nursing education, and this makes it difficult to transit from nursing education now into clinical practice. And in this regard, I think until those areas are looked into, the nursing education in my country has not kept pace with population needs.
Thank you very much. Well articulated. You're looking at really training and education that responds to people's needs. For example, you gave a good example of when we put a lot on midwifery and maternal and child health because in response to the high maternal mortality rate. And now, we need more in primary health care and all that. And indeed, I'm looking at Faith here, Nawagi has also talked in the chat box, has talked about that in many African countries, life expectancy has grown. In fact, I would say, before, if you did not die of HIV, then you tended to live forever. So we have quite a lot of, centenarians among us, yet we don't have people who are specialized in geriatrics or elderly healthcare, so that we need those kinds of things. Yeah, thank you very much, Sello, and also Faith for pointing that out. So, Mary Nandili, habari yako?
Sorry. Thank you very much. Habari mzuri. Professor, it's good to meet you again. To answer to the question number 4, ideally as a country, partially I can say that we have kept pace with the population needs in terms of nursing and midwifery education. We have had increasing number of middle level and university schools training nurses and midwives. Programs have also increased equally, and they're meeting the demand of the country and of the population. The production of graduates in the country is substantial to meet also the population and the requirement. The curriculums are usually developed harmoniously by all relevant stakeholders. I cannot really complain on that, except that we have limited funding to support nurses and midwives that require to upgrade and especially go for specialized courses like oncology, nephrology, among others. Funding is limited, and you'll find that most of the time priorities are given to medical officers and nurses are left behind. If you submit, let's say, a list of 400 nurses to go for training for a particular course, normally the government sponsors master's level, but not basic degree and higher diploma. So you submit a list of about 400 and you just 3 or 4 are given chances, while medical officers are given, you can find over 200 of them going to study. So I think there is no uniformity in that, and we really need intervention on that so that nurses can also be offered such courses of their need and to meet the need of the population. I believe, I think that is all that I had for now. Thank you.
Thank you very much. Thank you very much, Mary. I think you are right. Kenya has kept pace. In fact, is the one country where sometimes nurses could not be absorbed within the healthcare system, yet they were needed. But it was mainly because of some of these structural adjustment programs that were being imposed from outside to say you can only hire so much. So yes, limited funding for specialist nurses. I'm hoping that one thing that I was hoping that you mention is whether the funding is usually coming from the Ministry of Education or from the Ministry of Health. Because I found that where funding, the Ministry of Education is the one responsible for all education, they're actually able to be more neutral in terms of giving scholarships rather than where you put it all in the Ministry of Health. So, but let me hear now from Francisca Okafor, Niger.
Yes, thank you very much, Professor. Thank you for having me. I'm really delighted to be one of the panelists in this discussion. Well, nursing education in Nigeria under the robust regulation of Nursing and Midwifery Council of Nigeria has really evolved. And they have actually given us till 2023, to move nursing education all together completely into the university sector. Right now, we have up to 38 universities in the country offering a nursing at degree level. The Nursing Council, through regular review of its curriculum and mandatory continuing professional development programs, ensures that nurses and midwives meet the evolving healthcare needs of the populace. So be it infectious disease, be it non-infectious, as they evolve, nurses in training and nurses who are already practicing, have a way of making up to be able to meet up with that need. So the Nursing and Midwifery Council, through its education, certification, licensure, and discipline, I would say, meets the needs of the population. However, where we have our major gap is in our nurses ourselves, preparing the nurses to be able to lead, to be able to advance the profession. We also have challenge in nurse-patient ratio. Not that the country is not producing, we are not doing too badly with our yearly production of nurses, but due to rural-urban migration, due to even migration outside of the country looking for greener pastures, we find out that the populace, particularly in rural areas, are underserved. So therefore, there is a deliberate plan for recruitment and retention of nurses so as to mitigate the issues of patient-nurse ratio. So regarding the gap we have in positioning the nurses for leadership, currently the curriculum will be reviewed next year, and Nursing and Midwifery Council, I'm told, they are planning to deliberately impute leadership, advocacy, politics, and policy in the curriculum of student nurses, so that as they are in training and young, at that very young level, they start imbuing, leadership and advocacy and politics and the policy that they would use when they finally graduate to advance nursing. Another issue that is really affecting us is currently in Federal Ministry of Health, nursing is structured as a division under the Department of Hospital Services, which is always headed by a doctor, thereby limiting the director of nursing's access to the principals. You know, because before you can get to your minister, you must necessarily pass through your head of department. And if your head of department doesn't really buy the idea, that is where that proposal or concept would end. So this actually brings to fore what Judy and Kwambi pointed out regarding giving authority without responsibility. So although Nigeria has director of nursing at the department, at the Federal Ministry of Health, the director is not heading a department. Therefore, she is not part of the top management committee of the ministry. So this is basically the issues we have regarding serving the populace. We are poised to doing so, bearing in mind getting enough hands, recruitment and retention. Thank you.
Thank you very much. From you, I'm hoping that on the other side, I hope they did get the message that it is possible for us to do collaborating for health education, and actually for education of our nurses. The fact that everybody is now being educated at university level. A lot of our countries are not at that pace, and therefore it would really be great to look at that and see how you got to migrate to have nursing all being trained at degree level, and with good ratios. So apart from the fact that, yeah, you have said that retention of nurses, especially those who are to work in the rural areas, that is very important. We need to have incentives for that. But indeed, there's a lot to be learned in the case of Nigeria. Let me look into the chat box. I'm seeing just a lot of ideas being shared, which is really great. Academic institutions in Africa, advanced practice. Yeah, we actually had the ICNP, the advanced practice for Africa regional seminar just 2 days ago. So somebody Bongi has actually put up all that was happening there for the 2 days. We had right there, even looking at possible curricula. So let me now get back to with this. Okay, I still have a little bit of time. Then there are no questions in here except information. So okay, for the panelists in panel 1, is the voice of nursing loud enough in your country? And what do you think should be done to ensure that the voice of nursing is heard across Africa? So I want to talk about your country, but let's share also what can we do across Africa, because we are talking here collaboration. So let's not be just 2 country specific, but look at Africa as a whole, especially Francophone Africa, because you know what? It is being left behind. And those of you who are able to reach out to them, to the West African College of Nursing, to say, let's get together. Nursing now is here. The Nightingale Challenge is here. We really appreciate that. So with that question, I'll go again to Faith. Nawagi? Faith,
yes.
Yes,
I'm here. So please
it's
come
ready to
again.
say, is the voice of, it was ready to say, is the voice of nursing loud enough in your country? And what should be done to ensure that the voice of nursing is heard in Africa?
Exactly, yeah. So is it loud enough? Quite frankly, no, it's not enough loud in my country and in Africa, worldwide and everywhere. So how then should we lobby for it to make it loud? I think we have a common African saying here that if you want to go far, fast, go alone. But if you want to go far, go together. So I think we need to adopt the concept of collective lobbying as a joint health workforce with interprofessional collaboration. I think that will make us move far and ensure that we lobby for agendas as a health workforce, including doctors, nurses, pharmacists, all other health workforce that serves our population. That way we will be able to achieve more if we go together. I think we also need to change the dynamics of nursing in the sense of nurses can be contributors to evidence-based knowledge and practice in the health arena in Uganda and in Africa worldwide, and in Africa at large, meaning that we have seen many nurses participate in research, but most of the times they are the data collectors. You know, they are the research assistants who interview the participants and all that. But it's very key that we create a culture of nurses being the generation of knowledge through equipping them with skills to be principal investigators in research and also contribute to ensuring that their ideology of nursing around different disease cases and all that is documented to be scientifically evident and thus create change. I think much of the work on pain management globally has been a large effort on nursing research, which should also be effected within Uganda and in Africa at large. I also think we need to also sit and reflect back. Why is it that the voice of nurses is not heard? In that sense, we need to do a customer, like in companies that serve customers and all that, we need to also think of our patient load as customers. What is it that they feel as the nursing profession we should change to ensure that we serve them effectively? So I think then there needs to be something like that to be done, and therefore we will be able to enhance our lobbying because we are doing what is required and needed from our clientele who are the patients. Thank you.
Thank you very much, Faith. Collaboration and collective lobbying as a health workforce. So let me hear from Judy. But before I do, let me read in the chat box because Michaela has written something and also a question. She's really saying, as a nurse in the UK, I can't help but reflect how much my heart is saddened to hear a call for nurses not to be attacked, beaten or raped while at work. And she was actually saying, what can us nurses as in UK do to help nurses in Africa? So it seems like it's an Africa-wide problem because in Kenya, they had to change shift hours to give nurses more security. And I know that even in the Americas, you know, the shifts are not like you knock off at 12 midnight, which is sometimes our shift. They've done them in such a way that when you knock off, it's either you are going towards evening or you are going towards morning. So it becomes a whole lot better. So, but with that, let me get to you, Judy. I know you are the one who put this up. Is the voice of nursing loud enough?
Thank you, Sheila. No, I don't think it is. It's really not loud enough. I'm so glad that this year we've got the focus. I think COVID, one of its positives among all the negatives that we are seeing is that it has actually thrown into sharp relief the importance of nursing and midwifery and the work that nurses and midwives do. Sheila, I want to go back to the basics. Who becomes a nurse or a midwife? I think we've lost the plot somewhere. And I think it's important that we get the right people into the profession. Personally, I feel that we are not called angels for nothing. But I don't think not everybody is qualified to have that title. And I don't talk about academic qualifications, although those are important, but I talk about more than, just the heart. Number two, often you find in Africa, nursing as a profession and midwifery has sunk into disrepute and seen as, you know, a profession of failures, literally, that when you actually fail academically, then you're told, go and do nursing. I've had that from people, my family members, everywhere I've traveled around the world, in Africa at least, that oh, so-and-so has failed, let them do nursing. And I always, you know, rebut and say, do I look like a failure to you? And so I think this mindset starts in our mind, first of all. Do we interview the people who we take into the profession? Are we so clear in our minds as to who should be conveyed that title? That's the first thing. Because when that is corrected, then what we do will be seen. You know, people say you should not talk about what you do. People should just see what you do. And I think the reason our voice is not loud is because people don't see what we do. I'm currently sitting as the chair for nursing and midwifery at the university here in Kigali, in Rwanda. And my dean, who is a renowned surgeon, told me that we face challenges because we are not working together. And he says, one of the things we need to correct, Judy, is can we begin to work together? So we are competing with our fellow doctors, with other, even nowadays I see nurses are competing, community health workers, and so on and so forth, because seemingly we don't know what we are supposed to do. So let's go back to the drawing board and find what is it that nurses are supposed to do, which I know all of us in the deep down in our hearts know, and then do it. So that then this is seen across and people then say, this, you know, when the Minister of Health is asked, send so many nurses like Mary Nandili, our chief nurse in Kenya, is asking, but probably the decision maker is asking, even if I send you for this oncology nursing, what are you going to come back and do? Because he doesn't see us demonstrating. So one answer to your question, Sheila, is that we ourselves have to take a long, deep, hard look at ourselves and change and portray ourselves as that profession, Sheila, you're saying, where as a nurse, you would be escorted because the whole community cannot stand by and watch a nurse get raped and watch a nurse get stabbed, you know, because they see us as a treasure for them, for the community. When we do this, I am telling you, a lot of many of these issues we are discussing now will be fixed naturally. Just starting from there, Sheila. Thank you.
Thank you very much. Very well said. Indeed, you mentioned the silver lining in the cloud of COVID-19 that, you know, it has really shown the spotlight of the world on nursing. But we need to collaborate more to actually look at who are we recruiting into nursing. Is it that still that compassionate person who got in there because it's a calling? Or is it the person who just thinks, well, what is it that I can do? I'll take nursing anyway, but is in there not with their heart. So I think in Botswana, we call it going back to the crossroads. And indeed, it's applicable in all countries. These days, we don't get that. And, you know, much as the Nightingale challenge is there, and we are able to really invest in future leaders, sometimes it's really then having to sieve among those future leaders, where you find that sometimes in a whole class, those who graduated, you don't even find anybody who can be able to take that mantle. So we need to be able to do better than that, but collaborate even more on that. So, okay, somebody was saying, could the panelists speak a little about nurse migration within Africa and beyond? I'm going to go to the other panel, that's what they'll be answering as the last question. But now I'm going to go to Koyakhetsi. You know, I don't know if you'll be repeating yourself. Is it loud enough? But I think you should answer the question, what should be done to ensure that the voice of nursing is heard across Africa, you being the president of Hexacon. So Botswana alone, we are listening to you as Africa. Yeah, Koyakhetsi.
Thank you, Prof. Am I loud? Am I clear?
Yes, you are clear. Yeah.
Okay, thank you so much. Yes, going to the question of what can be done. I think what we can do as Africa is mainly to position ourselves Right. Positioning ourselves, I mean, we need to identify who we can work with. To start with, we have to start with ourselves. For us to be heard, we shouldn't be our own enemies. We have different levels. We have what we call the regulatory bodies in the countries. We have the training institutions. We have the office of the chief nurse, who we can say represent the ministry. And I have learned that when these people work together, and also the fourth one are the NNAs, or the nursing associations or nursing unions. Nowadays, there's a term that we use, which we call quad. This quad is these teams together. The NNAs, the chief nurse, the regulatory body, and the training institutions. So when they sit together and discuss nursing issues, issues will come from different angles. And then they take them up together. Be it for lobby, we need to do a lot of lobbying with politicians who can also help us, our voices to be heard. What I've learned is that when you lobby with parliamentarians, then you know that your issues will go to parliament straight away. So I want to encourage my colleagues everywhere in Africa to say, let us befriend people who can help us to take our issues up. So if we work together, then it will help us to be heard. I can just say, even though I don't want to be specifically to Botswana, but to give an example that so far I can say in Botswana, at least out of the 18 health districts, we have 8 nurses who are district coordinators. And this has really made me happy in a way to say, at least nowadays, at least the nurses, they can be recognized that they are able. Nurses are able to hold any position. So what we can do is just to work together and also make a lot of lobbying and make sure that we also include our partners in our countries. Let us not leave out partners. If we have people like WHO representatives, if we have JAPAIGO, we have AMRAF, whichever we have, we need to collaborate with them so that they can also help us, because when we take it as nurses alone, then it will be just like these nurses, they just want money, they want positions. But if we come along with other people who see what we are doing, then our voices will be raised higher than where they are right now. Let us also, I've realized that most of the time in other countries, we leave out private practice. We have nurses in private practice who are suffering, I can say, because when you are in private practice, it's not the same like when you are in public practice. So I think we need also to be their voices by including them whenever we have anything that deals with nursing, any collaborations, any deliberations, we need to have nurses in private practice as well. So I think if we can think along those lines of collaborating with partners in countries, collaborating with other teams, like I've mentioned, the Quad, then our voice will be higher than where it is right now. Thank you. I will stop.
Thank you very much. Yes, indeed, the Quad is very important, and the importance of collaborating, especially, as you said, with nurses in the private sector. Sometimes those are forgotten. We talk only of the government ones, the public service ones. And yes, I always say that when I'm in countries and I'm with nurses, because it's so easy to do in Botswana, I say to people, which MP are you collaborating with? And half the time, they don't even have access to their members of parliament. I said to them, but you voted them in. Get a member of parliament who can be able to get your issues to parliament and they can be discussed right on the floor. Better still, I usually say, get into parliament. None of you has mentioned that. I was hoping that somebody would say, look, we also need nurses as politicians to get in there and be able to really discuss and make that gender sensitive policies and legislation. So anyway, with that, thank you very much. And let me go now to the final panel, the panelists that will now talk about looking at, migration, in and out migration outside of the country. So how can we keep good nurses in our countries and avoid migration? Well, I guess it's good and the bad nurses. The bad nurses can migrate, but okay, how do you keep the good ones and ensure that they don't migrate? So that's the question now I'm going to ask Sello. You are number one because you are young. Let's see, how do we keep you in Lesotho and ensure that how we hope? Sello.
I think, hello, I'm back.
Yes.
I think that would be a very easy one. We have a challenge where I think globally, regionally, and even in Lesotho, nursing suffers a lot from not engaging talent management, where you find that you have challenges in recruitment, as Judy has already alluded to that. I think the nursing profession is sort of attracting, I don't want to say the wrong people, but I've seen a trend lately in which people are just coming into nursing because they failed somewhere. People had wanted to become medical doctors and they did not qualify, and now they come to nursing as a fallback. I think we need to correct the recruitment, as Judy has already said, and to truly manage the talent that we have in nurses, especially the young nurses, where there's proper allocation of nurses, looking at the characteristics that they have, the qualifications, the attributes that one has. I think I'll just make an example where you find that in Lesotho, you may have a nurse who has been trained in ophthalmology or nursing anesthesia, but you find that the placement is actually in the maternity ward or at a rural clinic somewhere. So this nurse who has such beautiful qualifications and talent is not fully being used by the government or the Ministry of Health to bring a change to health and to nursing in general. Number two is the controversial one, payment, remuneration. Mostly nurses, especially the talented ones and the ones with all the qualifications that are needed by our countries, they move in the name of going for greener pastures. So unless we correct remuneration in our countries, then I don't see how else we are going to limit migration. I think that's all I can say for now, Prof.
Yeah, well, thank you very much. You're talking about deployment as well as remuneration of nurses in, commensurate with their qualifications. And I've seen that a lot. Even when I was a minister, I had to have an open door, and a lot of nurses would come in to tell me, I'm a neonatal nurse, and guess where I am? I'm placed somewhere in the operating theater. And it just would irk me as to how that could happen when, in fact, we do need neonatal nurses. So sometimes it's really that we need proper deployment. Okay, let me see what the next person is going to say. Dr. Mary Nandili?
Thank you again. Nice meeting you again. How can we keep good nurses? One thing, there is this withdrawal syndrome. When nurses are in training, they are very active. But when they join the profession, they start withdrawing. I don't know really what happens until you will find that where there's a group of professionals, they tend to isolate themselves. That I've learned, and it should be corrected. And it's us to correct. It's our mindset that should come from our mindset. Foremost, we should streamline the system. the healthcare system to support both individual and organizational interest. We should also look at improving the working conditions, the environment where we are working, infrastructure, the structure, mainly the structure is a big gap, and also ensure adequate available resources to enable the young nurses or the nurses who are intending to leave to be retained. Because when the structure, just like the earlier presenters have mentioned, you'll find that nurses are supposed to be reporting through their channel, the chief nurse, but you'll find that the structure is kind of distorted. They even don't know who to report to, and the structure is kept changing in the ministry. That's a very big gap, and it demoralizes most of the nurses, and they take off because they at times get lost where they belong. Availability of working tools. You know, nurses are very innovative and they're very active, but you'll find that they get demoralized when they don't have adequate working tools in the wards. Right from the training, the practical aspect has a gap until now when they are already in the field. I think all that should be streamlined, and then we should harmonize and provide a appealing package, which has just been mentioned by the previous presenter. I think the package is more attractive, should be more attractive to appeal those who would wish or intend to live there for other greener pastures. We should also be able to encourage and provide for skills development. And open up, let's be broad, because a nurse could be having the basic degree as a nurse, but wants to move out and do economics or something else. Let's allow our nurses to choose what they would wish to do for their masters. Let's not really restrict them. And just as previously Judy said, we strengthen the office of the Director of Nursing or the Chief Nurse, and this will trickle up to the ground, because if we destabilize, or if the office of the chief nurse is destabilized, then it usually trickles up to the ground, and you'll find nurses are misplaced. This also can demoralize them and make them take off. We can also encourage them, nurses, so that we don't lose our nurses, to go for leadership courses so that they rise to top positions, because most of them think when they are in training, especially bachelor's degree level and a higher diploma, they have that mindset and mentality that they are supposed to be leaders when they qualify. But you know, these are a huge number of professionals. You cannot make everybody a leader. Let them take up leadership courses after the basic training. I believe that's from my own experience being on this seat. Those are some of the observations that I've gathered that makes most of these nurses take off. Thank you.
All right. Yeah, thank you very much. So we're talking about adequate remuneration and improving the work environment, both at work level, but I guess also in the country, because let's face it, if the country is in turmoil and you don't feel safe within your own country, then greener pastures becomes that safety to say, I'll go to another country where it is peaceful and I'll feel safer. So yeah, you are right. So let me now go to Francisca. Francisca, I'm sure you are the one, in Nigeria, you have experienced a lot of brain drain. So I think this question would be really appropriate for you, so that people don't go to London. Yes.
Thank you very much, Prof. We have come to the stage, in our professional development where we will be nurses, people who want to come into the profession are getting into our training institutions with the eye of
migrating to Europe, to Americas, and any other place to work in. And that is because the home condition is not really attractive. The world being a global village, and we all being global citizens, there shouldn't be any restriction for anybody who wants to go to greener pastures. So it's for our government to really look inwards and see how they can really make the working conditions attractive, better remuneration, motivations, and they're making the health sector, a bit less, how do I put it, militant, where, the doctor takes it all. If you want to advance yourself or advancing the profession, they see it as you want to, veer into their territory. And government keeps dancing to their tone, giving them everything, and I would say disregarding and disrespecting, with all due respect, I say it with all, level of honesty and sincerity, Right now, I'm at National Council on Establishment. I will soon be going in because we'll be called to present our memo. And what is that memo about? It's a memo on proper placement of graduate nurses. So we have brought our memo to the council to plead with them to place us at par with our fellow health care professionals. I'm not talking about the doctors, but I'm talking about medical lab scientists, physiotherapists, the optometrists, and all the other health professionals. They are taking one grade level above the nurses. Can you imagine that? With all that we do in the health sector, and the doctors will say, even the minister will say that if you enter a room and you don't see a nurse there, then it is not a hospital. Without nurses, they cannot run the health sector. The other cadres, you can improvise. I mean, they are not critical. We are at the front liners, yet you are a degree holder. You have spent 5 years in the university with the same entry qualification, the same basic qualifications. And then you come out, you go for internship for 1 year, just like any other health professional. Then you now want to enter the public service. They give you one whole grade level below the others. And if you want to understand the import of that, you are on a grade level for 3 years before you are due to write promotional examination. And depending on vacancy, depending on when you pass, because it's not automatic that after 3 years you are promoted. Most of the time they even pass the examination, but there is no vacancy. So that is where the nurses find themselves, and it has a way of demoralizing us. It has a way of keeping us down. We were in school together as undergraduates, and we come out, you're already high and above us. You find out that we'll now start moving timidly and sheepishly, because that's, what should I call it? Confidence is taken away from us just by mere placing us under. So aside from what every other thing the previous speakers had said applies, but at this particular point I need to bring up, because of the timing, that in a few minutes from now I'll be moving in, to go and plead. Meanwhile, our nurses, young nurses, have done the lobbying, seen all the heads of service from different states at the subnational level, because it's a federal thing. They have done the lobbying, so I'm just praying that the memo would go for today, because last year it was thrown out. Probably we didn't do enough lobbying, but we have done that now. So we are praying for good working environment, for proper placement, and for motivation, because we want to work in our countries. We don't want to
go outside and be second-class citizens somewhere else. Thank you, Professor Sheila.
Thank you very much. I think you did that emphasis that every nurse wants to work in that country. Nobody wants to be working outside. We want to improve the health of our own people, our relatives. And when we therefore are forced to have to go outside, it's because of certain factors that we need to be able to look at and see how our governments can address. We will definitely stay at home. So with that, let me now have the final, Beatrice. You are the final speaker, and then we'll look at the question and answers. Thank you, Beatrice.
She's not with us, Jude.
Okay. She's really not with you. Okay. Now, in summing this up, I want to come in because, you know, I'm foreseeing a situation after COVID-19 where there will be a lot of brain drain from Africa. Right now, we're seeing very little, mainly because I think there will be a hesitation until when that vaccine is effective. Because right now, a lot of people are thinking, you know, if I go to Europe, if I go to America, what will I do with all those COVID infections? But I know that once it's over, because of the shortages there, we can expect us in Africa to be particularly affected in the same way as during that time of the AIDS pandemic, when nurses really left in large numbers. Some thought they were going to be working. For example, I know a lot of our own nurses went to Europe thinking that they were going to be working in hospitals, only for them to get there and find that they're actually working in nursing homes, taking care of older, elderly patients. And they were already very, disillusioned, but hey, they were already there. So with the WHO code of ethical recruitment and all that, I'm hoping that that can be implemented. But for us in Africa, in order to avoid that impending brain drain, we need to really collaborate, do research, and make sure that our leaders are aware of the dissatisfaction in recruitment, in the retention and everything of nurses, and that they need very little to stay at home. I'm the one minister who lost very few nurses. In fact, 7% of when I was a minister, 7% of the healthcare workers had left the country. And it was interesting that another 7% came from other countries, because much as a lot of nurses thought there was the greener pastures outside, it just so happened that even in Botswana, our nurses were actually better remunerated than the other countries. So that I then had nurses from Zimbabwe, from South Africa, from Malawi. So we were able to patch that up. But it was not good to be able to drain other African countries. So let's just ensure that for the future, we work together, train more nurses, make sure that we lobby for governments to remunerate them, because it will happen. And as sure as COVID is here, it will happen. So with that, I'm going to now look at the chat box and see if there are any people who have put in questions. Is there, okay, Bongi is asking, is there a commitment from WHO Afro to have a regional chief nurse as in other regions? Dr. Moeti has gone, but she left one of her staff members here. So I don't know if they can be able to answer, they're able to go in or what. But definitely we do need a regional chief nursing officer, and indeed at a very high level and with proper staffing, so that he or she can be able to really deal with all those countries and ensure that the advocacy is felt at higher political level. So I don't know if I need to give somebody a chance to answer that, or should I leave it?
If I may.
Okay.
Thank you very much. I think, these conversations to me are so interesting. But one thing, as increasingly we are talking and exchanging our views and thoughts amongst ourselves, that's what is now, to me, one of the challenges that we need to undo. We are talking amongst ourselves as nurses, and we nurses understand our problems. not only do we understand our problems, we actually know the solutions to our problems. I don't think anything we are talking here is something new to anybody who is listening in. Everything we are saying has been written, has been researched on. Even as I was preparing for this panel, I was reading articles which give answers already to a lot of the issues we are talking about: migration, the need for leadership, the need for investment in nursing and midwifery in Africa. But the challenge to me is we seemingly can't penetrate beyond our level, within ourselves. How do we go above ourselves to talk to organs, that shape, I don't know how to call it in Africa? I am just thinking of what we already have on the ground, like AU, like WHO, Afro, like Bongi has said correctly, and other regional entities and bodies that we have in Africa. Because nursing not only impinges on health, it impinges on economy, for example. Can we speak to somebody like the World Bank, who gives funding to a lot of the health that we have in Africa? All the bilateral agreements that are signed are between countries, from Japanese government to Chinese government to the, Gavi, for example. Now we are looking for a COVID vaccine, and it's seemingly coming very fast. I read somewhere, I think the UK is planning for that on 10th of December, which is just around the corner, and the US and so on. When is the plan for Africa? But when these decisions are being made, I am very sure there is no nurse who is going to talk about the mechanics and modalities. Yet when they do finally come, I, Judy, will carry that vaccine and vial and immunize everybody as a nurse. That's the time they'll see that I am necessary. But at the point of the decisions at Gavi, at Global Aid, vaccine, all the trials that are being done, and so on and so forth, there are no nurses. So I think our decisions now need to go higher and above us. Let's stop talking amongst ourselves. It's good, and yes, but I think we need to talk somewhere up there to those who can make that deliberate and sustained change. I keep going back to the need for leadership, because I think, to me, that is where the problem we have here in Africa. Even when we do have nurses at decision-making tables, they don't know what to say. They don't know how to articulate themselves. Then often, like Francisca has said so sadly, that she is going to plead for something that should be taken as a matter of course. Why is it an optometrist? It's assumed she should be entered grade J, and a nurse goes in at a grade lower. And yet we do such important work. So where is the break? And I think having discussions with these people are what needs to propel us to get answers. Thank you.
Yeah, very, very good points. And I really feel, however, that sometimes when we were talking, we were not articulating a lot of what we really need within a committed setup. For example, right here, we have Hexacon. We also have the ICN. I mean, these are important bodies where I know if as African nurses, we can be going to the ICN, not as nurses of Botswana, of Lesotho, of Swaziland, but as nurses of Africa. This is our collective view. We can do that through our regional entities, SADC, and just make sure that we penetrate there. We start with our parliament, we go to SADC, we go to Hexacon, and we can then be able to say, WHO, this is what we feel. ICN, see what you can do. Because it's interesting that these bodies sometimes are able to even influence and say, can there be a nurse going to the World Health Assembly in the delegation? So it should not be just a nurse who's getting there to be listening to people. It should be somebody who can say, I am going, provided as we go as a delegation, the needs of nurses are well articulated as to what you are doing about it at country level. So it is really great. So, but Barbara has had a question. Barbara, I think I saw a question right here.
This is Jennifer from the region of WHO. If I can say a word, please.
Yes, please. Jennifer, you are welcome. Yes.
Thank you very much. The first point about having a specific person who is a nurse to head the region office, that I can only say I will communicate that to Dr. Moeti. but the feeling has been what you have just said. I think Judy and yourself, he believes sincerely that it doesn't have to be a nurse talking about nursing issues, but to make sure that strategically we have this on board. Right now we have, for example, if it wasn't for COVID, you'd have seen that. We have a whole work plan on the International Year of the Nurse for 20 to 21 strategies that we are doing. We are collaborating with the collaborating centers to move the agenda, etc. So what is correct, what you are saying, is to engage and to make sure. I'll give you an example. During COVID, we tried to engage as colleges of nursing, and West Africa responded. We communicated with the president in the Hexacon. We didn't get a response because I connected them to the emergency team to make sure that they get all the tools, they participate, they get their training. So I think part of it also is true. Let's be responsive when we are called upon, mobilize ourselves, and be there when we are needed. Otherwise, in terms of getting the messages, she's really committed to doing that, and she keeps on asking, do we have a strategy on moving things for nurses? We have in plan, after the global strategic directions of nursing, to develop one of our own. We are planning, if it wasn't for COVID, would have produced a status report for the region on nursing and midwifery, but it's on course now. We hope it can come out next year. We didn't want this year to compete with the global report. So there are things happening. They may have been quiet for now, but it's really coming up again, and we are doing our best. But I'll carry the message of what this meeting is saying. So we would really like to engage more for the different bodies that are working at Africa level. And some of the people on this call, we have engaged them to say where it counts, come up, represent. And the strategy is also that we don't have to have everyone here, but we are there to call upon the experts. When I'm at the global arena, right now I'm the one overseeing that. I told the global level, give me resources, give me the things. I have enough experts in countries of the region. If I need them to stand up for me to speak that, I can call on them, they can do it. It's the resources. So I agree with Judy that if we have resources, when I had the work plan, I sent it up. I said, Dr. Moeti, this is my work plan for the nursing and midwifery for our region. And we consulted the nurses. So the things are there. So it's capacity to do it. And I always insist, is don't hide behind it. We had one, a focal point who retired 5 years ago. And yes, we're slow to catch up, but it's really the resources. I tell them I have enough experts. I can call of them tomorrow if you give me resources. They can do the job. As long as we get the strategies right, the policies right, we can do it. So I think sometimes, yes, it is important. I'll keep pushing to get that, but I think it's really calling on you. When we call you, participate in this. When we engage you, be there, be seen at regional agenda, at global agenda, to represent the thing, bring it back to us, we'll package it and resource for it. That's what I can encourage you. Over to you, Chair.
Okay. Yeah, thank you very much. Yeah, we have heard you, but at the same time, do take that message back to Dr. Moeti to say that WHO, WHO at a global level has a chief nursing officer. And WHO in other regions have chief nursing officers. Therefore, we would like WHO in Africa to have a CNO. And indeed, you know, when I was minister, we actually had a CNO in the WHO office in Botswana. Those have suddenly disappeared. And here is somebody who's saying we had a CNO at WHO Kenya country office. That has so far been replaced by a medical officer. What is really happening at WHO? So that yes, that body is still very important, you know, rather than being talked for by somebody. We would like that somebody to be there, properly remunerated, properly resourced, so that they can then lobby, for nurses. Yes. So Euro has that, and even
yes.
yes.
Just to.
Yeah, no, I'm going to give you only 1 minute because we do have to close. I know this one we can stay in here forever. So is that Mary?
Yes,
Mary Nandili.
Yes,
yeah. Make it quick. I know, yeah.
No,
Okay.
just it's me who has posed that question about the country, WHO country office.
Yes.
I just want, I am requesting Jennifer also to submit that question to the regional office and ask why did they select a medical officer over time instead of the chief nurse to be in the Kenya country office. Thank you.
Yes, no, that I'm saying has happened in all our countries. When I was minister, we had a WHO and nurse at WHO. So I don't know whether it's funding. Maybe now that Trump has taken the money out, it may become worse. But Biden is coming in with, America will be part of WHO. I'm hoping it will be properly resourced to have those resources to at least have chief nursing officers at WHO Afro. That is very much needed. So I know this is something after your own hearts, but good people, we have been at this one for a long time. So it is now my pleasure to call Metembeka. We'll follow this up. I mean, the Secretariat has given you all the emails, Barbara Stillwell at Nursing Now Global, to be able to get this together and see how we carry this forth. So let me call Tembeka. I know she has said she won't be able to, we won't be able to see her lovely face, but Tembeka, we are now with you. You have heard it all. The second vice president of ICN, our leader at ICN, we please motivate us with some closing remarks. Thank you.
Thank you very much, my sister. And greetings to all the panelists and to all the listeners, especially nurses, and of course, those that are not nurses that might be listening. As Sheila have said, I'm Tembeka Kwakwa. I'm in South Africa in a rural place, hence you can't see my face because of poor network. Let me start, Barbara, by saying I was quite disturbed, to say the least, when I look at the numbers of participants. I was really looking forward for nothing less than 200. However, at times they say it is not the numbers that count, but not the quantity, but the quality. And I hope all of us that are here, we're going to be able to go back in our respective countries and take seriously what has been coming from the panelists. I give to you greetings from my president of ICN, Annette Kennedy, our CEO, Howard Cotton, the board members of ICN, and the staff. We were very delighted to be invited to do the closing remarks in this important webinar that has been organized by Nursing Now. Nursing Now, that for me has been very visible in the region, in the countries. And I want to say, Sheila, thank you very much. You have now put the honors to us as nurses in this region to say, how do we move forward? And Judy, each time you talk, you said things that I really wanted to say. Talking will not improve our situation. What is our situation? We always talk about we are not listened to, we are not respected. We know all these things. What is it that we need to do so that as nurses, we take our rightful positions in the healthcare system? For me, it starts by how are we organized at a country level? Then it goes to the region, then it goes globally. whom are we collaborating with at a country level, regionally, then globally? And I'm wanting to start with how are we organized as nurses at a country level? And what makes us to be organized? And what is it that we need to consider so that we can really be well organized, so that we can influence policy, so that we can be well respected by those people that we render services to them? For me, the starting point is to realize who a nurse is. Because I think that's where at times we have a difference. And therefore, how do we organize by ourselves is based on who do we think you are? Colleagues, nurses are both professionals and workers. And therefore, if we organize them, we must know that we're organizing workers, we're also organizing professionals. And therefore, if nurses are that, what kind of organizations must we have at a country level, at a regional level, and at an international level? I think, Sheila, for me, that really is very fundamental. And as a result, and you see how nurses are organized, even in this region, we do have regulatory bodies because we are professionals. We do have professional associations or trade unions or both. And again, going to that, how do we see ourselves? And then the question that we should ask ourselves, should we have separate trade union from a professional association? I don't have an answer there. It will depend on the dynamics of the country. And certainly, in terms of trade unionism, numbers, they matter. If you do not have a number as a trade union, you must just say goodbye. It will never be listened to. And I also, Sheila, I like the statement that each time you are in a platform of nurses, you always say health is politics or is political. That statement, I always listen to you and I would say, I wonder if other participants are listening to what Sheila is saying. Because for me, that statement is very, very, very important. But we've never asked you, why do you say so, Sheila? Right? And that is why now we find ourselves not being listened to. I remember during this panel, you also said you thought that the panelists also talk about that we need nurse politicians. So for me, that we also need to understand. And people have talked about the quad, that we need quad. And for me, that is so, it is so important. It is so important. I think, was it Judy or whoever who actually defined who the members of the quad are. And that is very important because whatever matter you are looking at, if you meet as a quad, educationists, they'll be looking at nursing from the education perspective. The associations or trade unions will be looking at nursing from that perspective, and the chief nursing officer from that level, and regulatory body from that level. And also the mistake that we make is that we think that if we've got a chief nursing officer, therefore everything for nursing will run smooth. That is not the case. We have heard the panelists, Judy, you actually said, we do want a chief nursing officer, but not as a window dressing. What is it that will make us to have chief nursing officers that have got chief nursing officers that are going to be taken seriously, chief nursing officers that are going to be given budget and the structure to run or to improve nursing at a national level? It needs all of us. to make sure that we are organized so that we can see. So remember, the chief nursing officer, the government is his or her boss. And we all know that you can never bite the hand that feeds you. And therefore, the only way to assist the nursing profession is to work together as the Quad. I remember some years back in Zimbabwe, the nurses in Zimbabwe, they were so organized. They used to say each time they were meeting the ministry, the first question that they would be asked was, are you coming here? It was a triad now, not a quad. Are you coming to see me as a triad or as an NNA or a chief nursing officer? And immediately the answer would be, we're coming here to you as a triad. Then you would see the ministry preparing themselves for really hard questions. Thank you very much. And everybody talked about collaboration. But whom are you collaborating with? Somehow as nurses, we think that the only ministry that we have got to work with is the Minister of Health. And yet our conditions of service, our education, whatever is get influenced by these other ministries outside Ministry of Health. For an example, education, those depending on how you get your salaries. For an example, in South Africa, it has got to be Minister of Public Service Administration. Maybe in other countries, it would be Minister of Labor, Ministry of Women, because the majority to those countries that have that ministry, because majority of nurses are women for now. Are we participating in all the activities that uplift or protect women, because our profession consists of women? For an example, if you look at ICN, the very same report, State of World Nursing, just the cover on its own, it speaks words. You will see Dr. Pedros. We all know who he is. You will see Elizabeth Iro, who is the chief nursing officer at international level, WHO. You will see Annette, who is the president of ICN. You will see Sheila, you are also there as the co-chairperson of nursing now. You will see Chris, who is also co-chairing with Sheila. The cover on its own teaches us to collaborate, and not only to collaborate with other nursing bodies only, but to look at what is it that you need, who is the best structure or person to assist me. For an example, Sheila, I was happy to hear that you were together at school with Dr. Moeti. That is important, colleagues, because we know at times it matters who you know. And therefore, Sheila becomes also, if we really want something from WHO, because she happens to know the director. So those are all the tricks that we need to use if we really want nursing to be improved at this level. You look at ICN, which is a global nursing organization, it collaborates with so many entities, not only the nursing bodies only. For an example, collaborates with WHO, I've already said the report. It collaborates with World Bank. It collaborates with pharmaceutical companies. It collaborates with ILO and so forth. For me, we need to collaborate. When it comes to leadership, there are so many programs on leadership in Africa. The recent one that ICN is an advisor in it, is the one that is going to be run by Harvard University School of Nursing, CDC, Union Africa, and ICN is an advisor there. So we really also need to learn, like I'm saying, collaborative. I know, Sheila, I've taken your time. Thank you very much.
Thank you so much. You definitely have not taken up anybody's time. You have been able to sum it up and really press the importance of collaboration and cohesion, especially at country level. So with that, Let me thank you, our closing keynote speaker. I want to thank our panelists. I want to thank our keynote speaker, Dr. Moeti, and please, Manyoni, have that message to Dr. Moeti. And indeed, I want to thank our Nursing Now Secretariat, who have been able to really steer this webinar so well. And I want to end with a word by Dr. Barbara Stilwell, what she's written here, to say that we will write up this webinar and make it available to all. It will be available as a recording. Let's keep talking. This is our moment. So indeed, nurses, arise and do remember that health is a political choice. With that, I'm happy to close this webinar. Thank you so much.
Thank you, Sheila.
Thank you.
Thank you.
Sheila.
Bye-bye.